Excellent presentation, ma'am. Our next speaker needs no introduction. He has been today awarded as the highest cited researcher in 2021 by Stanford University in Ziva. It's an honor to have Dr. Santosh Honavar with us. And Sir is going to talk about retinoblastoma.
Thank you, Aditya. Thank you very much for the invitation and the pleasure of sharing my screen on retinoblastoma. Basically, I'll be talking about what is new in retinoblastoma and what are we doing new in 2022. Is my slide see?
Yes, sir, we can.
Okay, great. So this is the evolution in the management of retinoblastoma. In the last 120 years, we have brought down mortality from 98%, which it was, to 98% survival. That kind of turnaround you can't expect in any other malignancy. That's a dramatic turnaround, mainly because of some of the newer forms of treatment that we have adapted. I'm going to talk about a little bit on what is new in classification, chemotherapy, management of vitreous seeds, high-risk retinoblastoma, and orbital retinoblastoma. We are very familiar with international grouping of intraocular retinoblastoma, which predicts eye salvage, and international staging of intraocular retinoblastoma, which predicts life salvage. What is new in retinoblastoma is the TNM classification. TNM is by AJCC, and the 8th edition of TNM, that is tumor node metastasis classification, has incorporated one more alphabet for the first time ever for any malignancy, and that is H. H is for heritability, which brings in genetics to the forefront in the diagnosis and screening of retinoblastoma. The next evolution is in focal therapy. We were very happy with cryotherapy and photocoagulation, and we had moved on to TTT, mainly because cryotherapy results in a much larger scar than the tumor that you began with, and also the risk of phlegmatogenous retinal detachment, although it has great success. And photocoagulation, because again, the scar is much larger than the tumor that you began with, because it's surrounded by 2 rows of large diameter laser spots, and also vascular occlusion, and the risk of visual field defects. So what's currently done is transpupillary thermotherapy, where the tumor is directly treated by a red laser, semiconductor diode laser, which acts by tumor cell apoptosis. Here, you don't photocoagulate the tumor, but gently heat it up to about 45 to 60 degrees centigrade, resulting in slow death of the tumor. The scar is never larger than the tumor that you began with, and the blood vessels that pass through the tumor are classically patent. What's new in TTT is photodynamic TTT, where we use the effect of indocyanine green synergistically with TTT. And that helps us treat tumors which are on amelanotic scars like this. This was a recurrence over a previously regressed scar, and that recurrence could not have been treated with conventional TTT. So when we inject indocyanine green, that makes it more potent, and consequently the tumor regresses. There's nothing new about plaque brachytherapy except the design of the plaque. This notch that you note here is a new design, relatively new design of the plaque, which sits around the optic nerve. Thus, we are able to treat tumors which are juxtapapillary, as you see here. Tumors which are hugging the optic disc can be treated because the plaque sits around the optic disc, and there we can treat it. There's one more example of a patient where there is juxtapapillary tumor treated with plaque brachytherapy. What's really new about plaque is that we make it in India now, reducing the cost to less than 5% of the imported plaque, thus bringing plaque into the armamentarium of many of the ocular oncologists. Chemoplaque is something that is new, that is happening, and we still are waiting for more data on it. Chemotherapy brought about a paradigm change in the management of retinoblastoma. These were the 4 articles that brought about a total change in the way we manage retinoblastoma, from radiation earlier to chemotherapy-based treatments now. This was in Archives of Ophthalmology, now JAMA, 1996, November. That's changed the entire situation as far as the management of retinoblastoma is concerned. Chemotherapy works very well. It shrinks the tumor. For example, this is one tumor here. There's one more small tumor there. You can see the scar that is produced is much smaller than the tumor that you began with. It becomes very important when you're treating tumors in a visually crucial area. So you have a smaller scar. That means that the child has a better chance of seeing. Second principle with which chemotherapy works is that the tumor always regresses towards its source of blood supply. it always holds on to its source of blood supply. Here, the supratemporal arcade is the source of blood supply, and the tumor is impinging on the macula fovea. And when it starts regressing, it regresses away from macula fovea. You can see after first cycle, tumor has left the fovea partly. And after 3 cycles, you can see that the macula fovea is fairly healthy and the tumor has moved away from it, thus clearing the area where there is crucial vision. So this again maximizes visual potential. Intravenous chemotherapy remains the standard of care in India, mainly because of its cost, which is affordable. But what is new in chemotherapy is the newer forms of delivering it: intra-arterial, periocular, and intraocular, again intravitreal and intracameral. We use triple drug intra-arterial chemotherapy protocol using a combination of topotecan, melphalan, and carboplatin. Here, an interventional neuroradiologist gets us access to the ophthalmic artery. Then we take over and inject 1 to 3 drugs. Melphalan is the workhorse drug. We also use carboplatin and topotecan. And the effect on the tumor is quite dramatic. Tumor starts regressing very rapidly, and this patient with total exudative retinal detachment has regressed to a calcified scar in 3 months. One more example of a large tumor regressed to a smaller calcified scar in about 3 months. And a patient who had a recurrence over a prior calcified scar again has shown nice response. So intraarterial chemotherapy makes a huge difference group D and D retinoblastoma and for larger recurrences, whereas for earlier stages such as A, B, and C, it does not really make a difference as far as the tumor regression is concerned. There is no difference between intravenous and intraarterial chemotherapy in smaller tumors. But of course, it makes a huge difference as far as systemic effects are concerned. Vitreous seeds were the major bugbear in the management of retinoblastoma. A bunch of vitreous seeds that were left after all forms of treatment are over. Current classification of seeds runs like this. We always knew the classic vitreous seeds, which we call them vitreous seeds anyway. But based on the OCT, under anesthesia, we can do OCT now. We have classified these as prehyaloid, subhyaloid, epiretinal, intraretinal, and subretinal. And intracameral, which are in the anterior chamber, are further classified as depository, which come through the zonules and deposit in the anterior chamber, which are absolutely harmless. And infiltrative are the ones which infiltrate the ciliary body, iris, and trabecular meshwork and get into the anterior chamber. How exactly do we treat vitreous seeds? We treat vitreous seeds currently by intravitreal chemotherapy, which is safety-enhanced chemotherapy. This was a patient where we use melphalan and the seeds are gone. Melphalan is the drug of choice in the West. But the problem with melphalan in pigmented eyes such as ours is that it starts producing complications such as cataract, uveitis, and more importantly, retinal pigment epithelial changes that preclude good vision. So we have introduced topotecan for intravitreal chemotherapy, which has better bioavailability, no retinal toxicity, and needs fewer spaced out injections. Example of topotecan, 2 injections 3 weekly, got rid of the seeds here. Again, 2 injections 3 weekly, got rid of the seeds in this situation, and the seeds are calcified after 3 injections in this patient. Only when seeds remain refractory, like this patient began with a tumor and a bunch of vitreous seeds. After chemotherapy, tumor is gone, but the vitreous seeds remained almost as they were pre-treatment. After 6 injections of topotecan, seeds are much less, but they're still present. Then we bring in low-dose melphalan and the seeds are gone. But you can note that RPE changes have started appearing. So melphalan is useful in low doses, but still it has retinal pigment epithelial toxicity. Intraocular chemotherapy, the extending indications are for anterior chamber seeds. These patients were earlier enucleated because we had no other way of treating them. Now we can safely treat them with intracameral chemotherapy. This patient received 5 microgram of topotecan. It's not toxic to corneal endothelium, at least clinically. We haven't been able to do specular on these kids yet. They haven't grown up enough for specular, but cornea remains clear in these patients. There is no cataract. A patient who has anterior segment seeds because of infiltration, as you see here, can be treated with dual therapy. Dual therapy is when we treat the ciliary body tumor with plaque brachytherapy and it goes away. And then we bring in anterior chamber intracameral injection of topotecan and the seeds also go away. One more effect of intravitreal chemotherapy that we have noted is on the subretinal seeds or epiretinal seeds. These patients were earlier treated with laser or thermotherapy. This would have created a large scar of this sort, which obviously would be detrimental to vision. Now with intravitreal injections alone, these seeds start going away and whatever that is left is sparse and that can easily be treated. Enucleation, everybody understands the need for a long optic nerve stump like this, but what is not understood is the role of pathology following enucleation. We only confirm the diagnosis in pathology following enucleation, but now we have a series of risk factors, which are called histopathological risk factors. And the incidence of histopathological risk factors is almost in half the patients that undergo enucleation in India. These are anterior segment invasion, which is infiltrative, trabecular meshwork, and anterior chamber angles, ciliary body invasion, invasion of the choroid more than 3 millimeter in thickness or more than 3 millimeter in diameter, and optic nerve invasion beyond the lamina criprosa. These are called histopathological risk factors. And in the presence of which, if you were to simply give adjuvant chemotherapy, then you can bring down mortality from 24% to less than 4%, thereby saving about 20% of children just by identifying these risk factors and giving them adjuvant therapy. So enucleation is not really the end in the management of retinoblastoma. Last bit is about orbital retinoblastoma. Orbital retinoblastoma can be clinically diagnosed as in this patient or radiologically diagnosed as in this patient. Earlier, we would do orbital exenteration, etc., with very high mortality. Now we have multimodal treatment where we combine the goodness of radiation, chemotherapy, and surgery in a sequential fashion to benefit these children. This is a child with orbital RB, you see that. And after neoadjuvant chemotherapy, eye has become a comfortable phthisis, at which point in time you do enucleation with a long optic nerve stump and deliver stereotactic radiation for the microscopic residual in the orbit, and then give adjuvant chemotherapy. This is about 12 months of treatment. This works for patients who have optic nerve invasion as well. You can see the optic nerve caliber being normalized after neoadjuvant chemotherapy. And for patients with intracranial extension, which were earlier only treated by palliation, now have a curative chance by multimodal treatment. You can see this child had anterior cavernous sinus involvement, gone with neoadjuvant chemotherapy, and all that is left is the superior orbital fissure amenable to stereotactic radiation. Cosmesis is a big bonus here. You don't have to exenterate these children. You can simply do a safety enhanced enucleation and you can fit a prosthetic eye, which looks really good. This is again a child with secondary orbital RB fitted with a prosthetic eye, and that looks good. So cosmesis is again a benefit. So orbital RB also now has a cure. With all this put together, Indian retinoblastoma survival rate is approaching almost that of the West. We have 95% survival now. Life salvage is mainly driven by neoadjuvant chemotherapy, understanding of histopathological risk factors. Eye salvage is mainly driven by intraarterial chemotherapy, brachytherapy, and intravitreal chemotherapy. And vision salvage is mainly driven by transpupillary thermotherapy and intravitreal chemotherapy. So in conclusion, I would say that there are a lot of advances in the management of retinoblastoma. It still remains an individualized management with multimodal therapy. Current trend is definitely towards chemoreduction and focal therapy with improving life, eye, and vision salvage. Thank you so much for the opportunity.
Thank you very much, Dr. Santosh Annal, for a very well documented presentation. One question I have is that, like in other cancers, is gene typing playing a major role in retinoblastoma? And if yes, those who have you had any experience with gene typing and identifying the type of gene, especially with Foundation in the United States?
Right. They are, gene therapy is being tried in retinoblastoma, vector, especially vector delivered gene therapy, but it's not been successful so far. So there are efforts going on regards gene therapy, but well, it's a long way ahead.
Thank you so much, sir. It was very heartening to see that retinoblastoma can be now taken care of. Most of the types can be taken care of by focal therapy, and beautifully shown that how it has improved. Not only do they live, they also see. So I think that's true to your talk. And thank you for being here with us, sir. And congratulations once again for today's achievements.
Thank you so much.
It was very heartening for all of us, very inspiring for all of us to see that you were rated as #1 cited author from India. And we all wish to follow your footsteps.
Thank you so much. Thank you so much, Aditya.